Respiratory arrest and advanced airways is our focus for this session. This module covers the critical transitions from basic life support to advanced interventions. We will examine how to identify respiratory failure, the proper use of basic airway adjuncts like OPAs and NPAs, and the progression to advanced options, including supraglottic devices and endotracheal tubes. Additionally, we will analyze the vital role of waveform capnography in monitoring ventilation quality and predicting patient outcomes. Understanding these protocols ensures that every breath delivered maximizes the chances of patient survival, while minimizing potential complications during resuscitation efforts. Recognizing respiratory arrest is the first critical step in management. The definition of this state is when the patient has a palpable pulse but is not breathing or is only gasping. Once identified, your immediate action must be to open the airway and provide rescue breaths to maintain oxygenation. Regarding the frequency of these breaths, you must deliver one breath every 6 seconds, which totals 10 breaths per minute. While providing this support, you must check the pulse every 2 minutes to ensure the patient has not progressed into full cardiac arrest. Basic airway adjuncts are essential tools for maintaining patency. The oropharyngeal airway, or OPA, is intended only for unconscious patients with no gag reflex to prevent airway obstruction by the tongue. To ensure a correct fit, you must measure from the corner of the mouth to the earlobe. Conversely, the nasopharyngeal airway, or NPA, can be used on conscious or semi-conscious patients who still have a gag reflex. For this device, you must measure from the tip of the nose to the ear, select the appropriate size for the patient's anatomy. Advanced airway options provide more definitive control during a code. Supraglottic airways, such as the LMA or King tube, are often easier to insert than ET tubes and are highly effective for transitions between BLS and ACLS. Endotracheal intubation remains the gold standard for airway protection, though it requires direct visualization of the vocal cords for placement. The 2025 recommendation emphasizes clinical flexibility, advising providers to use the device they are most skilled with. Most importantly, you must not delay chest compressions for the sake of attempting intubation. Waveform capnography, or ETCO2, is a vital monitoring tool. It is currently the standard and is mandatory for confirming and monitoring the correct placement of an ET tube. Beyond confirmation, it is used for monitoring CPR quality. Specifically, if the ETCO2 reading is less than 10 millimeters of mercury, you must improve the depth or rate of compressions. Finally, it is crucial for predicting ROSC, as a sudden significant jump in ETCO2, usually reaching 35 to 45 millimeters of mercury, is an early sign of the return of spontaneous circulation. Ventilation risks must be carefully managed to avoid harming the patient. Hyperventilation occurs when a provider gives too many breaths or uses too much volume per breath. The consequence of this error is an increase in intrathoracic pressure, which decreases venous return to the heart and ultimately reduces cardiac output. To prevent this, follow the rule of giving just enough air to see visible chest rise. This ensures adequate oxygenation without the hemodynamic compromises associated with excessive pressure, maintaining the delicate balance required for successful resuscitation and stable perfusion.